Oh,
All
and
right,
we're back.
we're back. Well, apologies, we've been having some technical difficulties. But we're again joining Dr. Bob Twillman. We're discussing rates of fentanyl positivity among urine drug test results positive for cocaine or methamphetamine, part two.
Right, part two. And the question I asked, and Bob, you may not have heard it, but I asked Seth, is we hear a lot about carfentanil and sufentanil as kind of these really pure and really potent versions of fentanyl that are tainting the drug supply and causing an increase in overdose deaths, at least according to kind of consumer news stories. Tell us about how that story or that narrative fits into your findings, if at all.
Well, we didn't test for anything other than fentanyl. So we didn't test for the carfentanil or alfentanil or any of the other fentanyl family members. So, I really can't comment on that. But, I think the risk is that if that's in fact what's happening, then that's even more deadly because those other analogs are even more potent than the fentanyl itself. So if that's happening out there, that may also account for some of the increase we're seeing in the overdoses.
Okay.
Yeah, and I mean, from the numbers, I remember seeing a review, I think it was last year, that something like 60 to 70% of opioid overdoses in the ED had some sort of fentanyl analog in them. And so there's probably, just the magnitude of your findings are probably substantially higher than what you can report because you're doing such specific testing.
Right.
My biggest takeaway from that is we basically are moving away from using the term heroin overdose and just have to call it an opioid overdose because we don't know what people are getting. And it certainly helps explain why overdoses have increased.
Yeah, it really does. And yes, we do have to call it opioid overdose. The only downside to doing that, and I recognize the need to do it, but the only downside to that is that then it makes it difficult for us to distinguish the prescription opioids from the illicit opioids. And there are different solutions for those different problems, I think.
Mm-hmm. Yeah, well, again, I'm still an optimist. There's lots of opportunities for improvement and things to do better here. So the fact that we can't cleanly or neatly divide them, also there is some, as much as we're not as physicians entirely responsible for the opioid epidemic, there is some entanglement and some I don't know, complex causal arrows back and forth.
Culpability.
Culpability. Yeah, I don't know. I'm still young enough that I'm not taking any of the culpability. I came after this.
No, I was around for pain is the fifth vital sign. When that was really pushed through, particularly the VA system with a lot of these vets where I was practicing at the time who loved the fact that pain was a fifth vital sign. Mm-hmm. And we encourage them to kind of talk about how much they hurt.
Right. And again, in all seriousness, I still believe we have both an oligoanalgesia problem where we're undertreating pain and an opioid epidemic where we're overprescribing for pain. And then it just kind of fuels there's so many different moving parts here. And you add the fentanyl and fentanyl analog supply that's contaminating supplies. I don't think anybody is intentionally using fentanyl. They're using opioids that are contaminated with fentanyl or more potent fentanyl analogs and vastly increasing the risk of overdose without necessarily increasing the euphoria or recreational experience.
Right. The whole overdose thing is really very complex, and it's a conjunction of really three major public health problems for us: the problem of chronic pain, the problem of opioid use disorder, and the problem of other mental health conditions, which doesn't get as much play as it should in understanding this whole thing.
Yeah, and to get back to your paper, that was one of the things I found really interesting. And if we can show the visual abstract, if possible, if the computer's alive again, I found it interesting the rates of different fentanyl positivity by specialty type. It varied from in the pain management patients, it was only 5 to 6%. In the patients who are undergoing substance use disorder treatment, it was 10 to 29%, which is a huge swing.
It was shocking to me that, in the case of the methamphetamine, it actually looked like it was about as common among sort of general practices as it was among the substance use population. But otherwise, it really does seem like it's something that's much more common among that substance abuse treatment population.
Right, and what do you make of that? And then we'll finish up. I wasn't quite clear whether that implicates the physicians or the practice, or whether that implicates the patient demographics within those practices. I wasn't quite sure what lessons to draw from those differences by specialty.
Yeah, it's not something we've really had a lot of in-depth discussion among the team about, but I think it probably indicates a lot more about the patients than it does about the practices. We know that people who are coming into a substance use treatment program are going to be folks who are pretty heavy users in general and maybe more likely to be the ones who are engaging in the kind of speedball activity that we talked about earlier, and chasing the sedative effects of the fentanyl with the stimulant to overcome it. So I think it says a lot more about the patterns of use within those populations.
It makes a lot of sense.
Yeah. Yeah, absolutely. I agree. So really, this is a really interesting study looking at 1 million on the nose randomly selected urine tests, which I not only love big numbers, but precise numbers are always kind of fun.
Well, it's the zeros you're impressed by,
Right,
right?
absolutely.
Okay, well, it's great work, and we really appreciate your submitting the paper to JAMA Network Open, and you're joining us for this conversation.
Yeah, despite our technical difficulties.
Right.
Thanks again for putting up with us.
Thank you.
Thanks for talking to us.
Uh,
And Seth, I'm going to follow up. Today, JAMA at JAMA.com published a medical news feature on this issue of oligoanalgesia, as you refer to it, because the CDC guideline was published in 2016 and has, kind of spoke about limits. I think it's like 90 morphine equivalents is kind of a rough estimate for the amount that people should be prescribing. And I think the pain advocacy community, if that's the proper phrase, have been highly critical of the guideline and of the way insurers have been using the guideline to limit coverage for prescription drugs, opioids in particular, for patients who need them for either cancer or non-cancer pain. So we have a great news feature at JAMA released today, Monday, April 29th, talking about the kind of the pro and con of limiting opioids in guidelines and elsewhere. So check it out.
Right, and we certainly don't want to throw the baby out with bathwater. We don't want to stop controlling pain appropriately just because there's inappropriate pain control and substance use.
Right, and that's by Rita Rubin, one of our crack medical news writers.
Great. All right.
What do you have next?
So next up, the Association between State Medicaid eligibility thresholds and deaths due to substance use disorders by Dr. Thornton Schneider and colleagues.
Right. So this has to do with, I think, right, the Medicaid expansion. Some states took it on, and some states didn't, in opposition to the Affordable Care Act, in principled opposition to the Affordable Care Act. And in general, I will say, across the network, we've been publishing papers that show that the availability of coverage, insurance coverage, that comes with expanded Medicaid eligibility has brought public health benefits.
Right.
So what did this paper look at, and what did it find?
Right. So they looked at basically what states' general threshold was for Medicaid eligibility. So in general, to be eligible for Medicaid, you need to earn below a certain amount of the federal poverty limit, so a percentage of the FPL. It's all over the place in different states. And before the Affordable Care Act, it was generally a combination of two criteria. You needed to be pregnant and make less than 200% of the FPL in a state, or a child to make less than 8%, or a childless adult to make less than such and such percent. And it was all over the place in different states. It changed over time in a bunch of different states as their supplemental appendix shows really interestingly. And there's the kind of, I think, typical geographic and political divides that you would imagine with this sort of thing that follows a lot of electoral maps. The Affordable Care Act expanded Medicaid, so basically everybody who makes up to 138% of the poverty limit would be eligible for Medicaid. But with the Supreme Court decision in 2012 that upheld the Affordable Care Act, states could decide whether or not to expand Medicaid, and again, follow those kind of political electoral patterns. And these authors took advantage of that kind of variation to make estimates based on what were the Medicaid eligibility thresholds over time, and how did that track with substance use disorder deaths, and how many deaths could potentially be avoided if more states expanded Medicaid.
Got it. So that's the setup. And you may not remember, I think I remember, in August or September, we talked about a paper that looked about expanding Medicaid eligibility and the availability of naloxone buprenorphine. And if I remember correctly, that pharmacoepi study showed increased availability of that specific substance use disorder treatment, suggesting that it had a favorable effect on the public health crisis in the United States of opioid use disorder.
Yeah. So interesting. So they looked at from 2002 to 2015. They used They used one specific measure of adults' income eligibility threshold because it's so all over the place, and then basically did economic analysis to figure out what the estimates would be, and basically found that, and you can see in Figure 2, could save essentially hundreds of deaths per state per year if Medicaid eligibility was expanded to at least the Obamacare floor. I think the overall estimate would have been, I lost it, oh no. One of the problems with the complex health policy stuff is there's numbers all over the place. They estimate about 2,400 fewer substance use disorder related deaths in 2015 if all of the states had expanded Medicaid.
Compared to those who did, right?
Right. Yeah.
And they're not looking at pharmacy databases here to say what the mechanism would be. They're just looking at kind of a global ecological association between this policy change and these kinds of numbers of events in these states.
Right, exactly. And they're using plausible estimates from existing data like what you mentioned of how these numbers change and all sorts of advanced analyses and things like that. They break it down into what the per state would be in Table 2, which is too small text for us to show on the screen, but basically take Kansas, for example. There are 627 substance use disorder related deaths in 2015, and they projected there would have been probably about 40 fewer, so between 0 and 80. Mm-hmm. That's a low number, but that's one state in 1 year with a relatively slow population. 40 out of 627 is a lot of people.
Right. So health policy and health coverage, insurance coverage, may save lives.
Right.
That's causal language. We don't want to say that. Is associated with the saving of life, according to certain models.
Well, we project that it would be associated with saving life based on other pieces of the puzzle that we know about Medicaid and other things we know about access to care. And it's just no real surprise that people have access to care, have access to mental health care, which includes substance use disorder care, which means it's probably you're more likely to get appropriate treatment for your substance use disorder.
Right.
Yep.
Okay, so there's a lot of policy debates in this country about what to do with healthcare. If it's not going to be the Affordable Care Act, what's going to replace it? If it's going to be the Affordable Care Act going forward, should we expand Medicaid? Should there be, other expansions of Medicare for all, and so on? So this feeds into a very hot political debate entering into presidential elections in 2020.
Right. Yeah, absolutely.
All right, so that's another great paper. What else was published this past Friday?
Great, so we'll do our run through of the table of contents. Our featured article this week was looked at the link between childhood oral infections, so basically dental caries and other oral infections, and later development of cardiovascular risk factors like type 2 diabetes, high cholesterol, et cetera, as an adult. And they also did things like coronary intimal thickness.
Carotid.
Carotid. Was it carotid? Yeah.
I thought it was
carotid. I
carotid.
thought it was probably carotid. I'm a simple ER doctor. It's all important arteries to me. And basically found that there was an association. And there's an accompanying editorial that looks at it and describes it very interestingly, where it's hard to know exactly what the causality is here.
Right.
There actually is a surprising amount of data that it is very specifically causal, that like the microbes that cause oral infections actually go into the artery walls in other parts of the body and cause atherosclerosis and lesions and stuff like that, which I thought is really interesting and cool and kind of scary. Although a lot of it's probably kind of collinear. People who are more likely to have child infections as kids are probably at the lower end of the socioeconomic spectrum, who are more likely to have all the other risk factors that lead to cardiovascular risk factors.
Right, and the childhood dental infections are specifically clinical signs of periodontitis and caries, if I read the paper correctly. And it's hard to know. I've seen the needle move back and forth. There's this kind of really appealing notion that oral health and dental health kind of has this creates this pro-inflammatory milieu that will end up being pro-atherothrombotic, if I have that correct. And I've just read something, that there's this kind of trendy theory that it's actually oral microbiome influences risk for dementia as well. Yep. So it's really easy to kind of chase that idea, but I'm not sure that the data are there in any meaningful way.
But if I'm again an optimist, so it's one of those things where we work to eliminate health disparities and socioeconomic disparities, and maybe just work to get people better teeth, even if it only fixes part of that puzzle. That seems better for everybody.
Well, that's where I was going to follow up up and land this discussion, which is who's to argue with good dental care for your kids.
Right, exactly. Even in stuff that doesn't seem totally specifically relevant, just people with worse dentition are more likely to turn people off at a job interview or something like that, or just in the street.
Well, the pivot, we published an article that got a lot of attention last week in JAMA Pediatrics, which was really kind of the epidemiology of the types of drinks that young children are imbibing, and there was a surprising number that hadn't touched water in a long period of time. So they're either drinking sugar-sweetened beverages or artificially sweetened beverages instead of water in a way that probably has a tie-in to this conversation and other kind of gloom and doom concerns about the overall public's health and how our kids are developing.
Yeah, and again, my wife's a dietitian, but not to put words in her mouth, but she can't understand why anybody thinks juice is healthy and that we're basically all in the pocket of big juice.
Well, yes, unless you actually take fruit and squeeze the juice.
Even then.
Yeah, she doesn't like that.
Basically just sugar.
Okay.
Yeah,
Great.
sugar water. All right, again, I'm not speaking for her. I'm not allowed to.
What's next?
Next up, disaster exposure, mental health among Puerto Rican youths after Hurricane Maria. So Hurricane Maria was pretty devastating to Puerto Rico. Unfortunately, not only did it expose a lot of locals to basically bad things, burn down houses, other signs of destruction and disaster. But as we know from prior experience, there are links to things like depression and PTSD, and they did find a link with things like PTSD symptoms. And of course, the terrible irony is that because so much infrastructure is destroyed, that also means there's less access to mental health services for people who now need them more.
Right, and we see that even in the United States after Katrina and Hurricane Andrew and things of that sort. This got a decent amount of attention, kind of activist attention, I think, in my opinion, rightfully so, on Twitter over the weekend. People were saying we really need to push for more support for Puerto Rican health facilities and the population in general.
And to log roll myself a little bit,
Yes.
in 2010, I was a resident. I rotated with a TV news network show as like a medical news show, and helped look. It was I started during the week of the Gulf oil spill, and one of the first tasks I did was basically investigate what do we know about health effects of those kind of disasters, and basically from what I remember from what I found in 2010 was basically it was all mental health stuff. Is that we know there's depression, there's job loss, there's PTSD, there's that sort of thing. Everybody who watches the news seems to be worried about oh, is this oil and stuff going to get into my food and drinking water and make me sick directly? And all the best evidence is that really the mental health impact is really more devastating than we think it is.
Okay.
So, obscure fun fact about me.
Yeah, and we need, we talk about disaster relief, but those are usually like high optic kind of housing, all of which is important, and kind of shelter, and but there's long-term consequences of these of these large environmental disasters that unfortunately we may see more of if climate change is going to kind of visit our cities soon.
Yeah, so nice segue into the next paper that looked at the rates in Uppsala, which I'm sure I'm mispronouncing, in Sweden. They looked at the organic pollutants and mortality risk, and basically people who were exposed to organic pollutants, primarily PCBs, were more likely to have higher all-cause mortality, including and especially cardiovascular mortality. Okay. So pollutants are bad for us.
I was going to say pollution is bad.
Yes, pollution is bad in multiple ways. Okay. And I'm sure it has all the socioeconomic disparities that we associate with that kind of exposure as well. Next up, switching gears a bit, there's a systematic review and meta-analysis of outcomes of traditional inpatient or clinic-based versus home-based rehab after total knee replacements. Basically found that home-based rehab was as effective as clinic or inpatient-based, which is great because people can, if it's easier for people to get rehab at home without going to a medical place, that's wonderful. There's, I'm sure, some commercial interest here where if you can, send somebody an iPad that their insurance company pays for and provide their insurance there. There's commercial elements. There's reasons why it would be cheaper for many of the people involved.
Right. Just walking through the door of a health structure, I think, costs a lot of money. Yeah. Right. And this makes total sense to me. And I've been thinking, and it's easy for me to think, but there's so much billing that goes on in health facilities. You may be too young to remember the time when doctors used to visit families in their homes.
I've read about it in books.
And I would like to see the return of a kind of a house visit or a home visit, which of course our nursing colleagues and our physical therapists and other colleagues are participating in, but physicians should be there too.
Yep.
There's no better way to learn about a patient. And I had the privilege now already a number of years ago in the VA system of being able to drive to patients' houses and take care of them there. And really, there's no substitute because you get about 50 million times the information you do from a 20 or even 40-minute office visit by visiting them in their home.
Yeah. Yeah. And I mean, just the people who need rehab, there's so many different barriers. You need to be able to get into your car or bus. You need to be able to get to the clinic and get, up the stairs to the clinic, all that other stuff.
Right.
You need a lot of resources, a lot of support to do that.
Right.
And I would imagine that the people who could benefit from rehab the most might be the people who it's hardest to get out the door to do that.
Absolutely. Now, I'm not sure who's going to pay for it, but I can wax philosophic and think about like an Uber physician thing where somebody needs help and you enter it in your app and the closest doc visits or something like that.
Right.
But we could talk about it. But I think there's probably a role for that kind of care and healthcare delivery.
Right. And I'm optimistic about some of the unrealized potential for telemedicine in this situation.
You are very optimistic today.
It beats the alternative and the weather outside.
Right.
We had a big snowstorm this weekend, which is very strange at the end of April, or not strange, very unsettling at the end of April.
Yes. What's next?
Next up, McCarthy and colleagues looked at the association of a new way to judge hospitals against closer peer institutions in the hospital readmission reduction program. So one of the things from Obamacare is the hospital readmission reduction program, that basically hospitals get penalized if their patients for certain procedures or conditions need to come back into the hospital and get rehospitalized. Not always, but sometimes because of things like poor post-discharge planning. And one of the problems is that if a lot of it is you take care of patients who are more vulnerable, don't have access to outpatient docs, don't have support at home, et cetera, is your hospital being punished, getting financial penalties for taking care of sicker, poorer patients. And basically, it looks like they're moving towards essentially stratifying into, I think it's quintiles. So basically, hospitals who take care of more poor patients, more dual eligibles, et cetera, only be compared to similar hospitals.
Right. So what did this paper do? It shows that that's a feasible thing to do?
It's feasible, and the penalties would go down because you're not comparing the fancy hospitals that take care of richer patient populations to more resource-strapped hospitals taking care of more vulnerable populations.
Right. I mean, my view, and I think we've talked about this in a prior episode, is that this is always going to stymie these efforts to incentivize quality of care, because somebody that ends up costing more or looking bad against these quality measures is going to say, you don't understand, our patient population is different.
Right.
And there's always going to be some manipulation of the frame or the numbers to demonstrate that that's the case.
Right. And the goal here is to say, well, we're only going to compare you to peers who take care of similar non-different patients.
Right. So which is laudable. Let's leave it at that.
It's not perfect, and we could probably have a whole series of shows just about that.
At the
general
HRPP.
principle.
Okay. And we have one more, I think.
Yeah,
right?
one more. This is one where they looked at modeling and surveillance of reports of mosquitoes and humans infected with West Nile virus. And basically, it's hard to track mosquitoes. It's very easy to. It's hard to track mosquitoes. It's hard to track diseases like West Nile virus. There's delays to reporting both. So when there is an outbreak of West Nile virus, it's very hard to forecast or project which way things are going or what the current epidemiology is, because it's hard to count and hard to do this stuff. And this is why I don't do epidemiology.
Right. Well, I think we've gone from West Nile virus to yellow fever to Zika, so that we were skipping over X, but I think we're due, like the hurricanes, for an A in epidemic outbreak now.
Right. Hep A? I think wasn't there a Hep A outbreak recently somewhere? I feel like there was something.
not recently, but in any event, let's hope there's not. West Nile virus is actually probably we're gonna hear more about it with kind of weather extremes in different places and changes in the mosquito vectors. So this is still a relevant paper.
Yeah. And I've been, I'd say, maybe an audience member for casual debates about whether or not to do lumbar punctures for patients with suspected viral meningitis. And I think because one of the questions if it's viral meningitis is really that dangerous. These aren't patients who need, big doses of ceftriaxone, et cetera, et cetera.
Right.
And I think one of the little things that makes me think about doing it more is if we can do things like find out, hey, we are starting to see West Nile virus or I don't know, X-linked immunoassay virus or whatever is next in the alphabet, then it's helps with the epidemiology for that in the track.
Right. Well, I assume NGS, next generation sequencing, is going to get to a point where you can draw a blood test and make that diagnosis.
We'll see.
I mean, maybe I have NGS wrong because that's genomic sequencing, but it would be genomic sequencing of kind of, the West Nile virus itself in the bloodstream.
Sure. Well, I was talking about viral meningitis in general,
Okay.
but mostly because I just like to say meningitis.
Right.
Almost as much fun as saying anti-NMDA receptor encephalitis.
Right, which didn't exist when I was coming up
Right.
as a young
Or
man.
it did, you just didn't know about it.
Right, exactly.
Okay.
Right.
Great. Well, thank you for joining us. As always, follow us on all our social channels at JAMA Network Open on Twitter, Facebook, LinkedIn, I guess Periscope and Pinterest as well.
Right.
Join us next week. We will probably be on Tuesday at 11:30 with special guest editor-in-chief Fred Rivara.
He's going to be taking my place, so I won't be here. I get the week off, but Dr. Rivera will be here, and he makes all the decisions, so you can ask him your questions directly.
Great. But he can't tell you whether they're going to accept your paper.
Right. And check out our podcasts, our translations into English and Chinese, and our new material always shows up Fridays at 10 a.m. Central Time, which is Greenwich Mean Time -5. We'll see you next week, Tuesday, in the morning around 11:30 a.m. Central Time, and thanks for joining us.
Yep. Thanks for putting up with our technical difficulties today
Yeah.
as well.
Take care. See ya.